Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, along with my producer, Lindsay, and we are streaming from downtown East Wenatchee, Washington today. Beautiful sunny day. And today we have Dr. Diana Girnita back. She has been on our podcast before, and she is a rheumatologist and specializes in autoimmune disease, and that's what she's going to be talking about today. Autoimmune disease, you guys have probably heard about that. How can it affect your cardiovascular disease, your cardiovascular health, your heart health, if it goes untreated? And also, if we have time in this quick half hour, we are going to discuss NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen, like naproxen. Many patients take them. How do they affect your cardiac health long term? So, Diana, welcome back to our show.
Shawn, it's such a pleasure for me to be back on your show. I think it's a valuable resource for patients, and I want to thank you, and I'm going to tell you how honored I am to be back.
Well, thank you, Dr. Girnita. I really appreciate it. And if you don't mind, to the people that have not met you before, our listeners and viewers, could you give yourself a quick introduction so they know who is talking?
Yes, definitely. So my name is Diana Girnita. I'm a rheumatologist. I've done in my whole career a lot of teaching and as well as clinical. I have an extensive clinical experience. I also have a background in cardiology and a PhD in immunology. And I'm very fascinated by your topic, which is the cardiovascular impact in our autoimmune diseases. I have started a company, which is probably the first and the only telemedicine company for rheumatology, to broaden the access of patients to this specialty. And I do offer them a very individualized approach where I combine everything that I know, from evidence-based medicine to integrative medicine.
And what is the name of your company, Dr. Girnita?
The name of the company is called Rheumatologist On Call, and I practice in 6 states, which are California, Arizona, Ohio, Indiana, Kentucky, and very soon in Texas.
Awesome. I love it. So who better qualified than a rheumatologist who has a background in cardiology to talk about autoimmune disease and how it affects the cardiovascular system if it's left untreated? So why don't we go ahead and dive into that topic?
Great. I'm happy to answer your questions.
Yeah. So talk to us a little bit about, let's just define, what is autoimmune disease? I mean, I think we hear the term a lot. Maybe some people aren't familiar with it, and I would love an update and your definition of what autoimmune disease means.
Definitely. So autoimmune diseases are diseases that are triggered by our own immune system directed towards our own body. So when our body is encountering something foreign, the immune system starts to respond to that. And sometimes this response is exaggerated. It doesn't stop when it's supposed to stop, and that will lead further on to what we call autoimmune diseases. So auto means ourself, immune, triggered by the immune system. And there is a wide variety of autoimmune diseases, not only in rheumatology, but they can span into neurology or gastroenterology. So today I'm going to talk primarily about autoimmune diseases that we treat, such as rheumatoid arthritis or lupus or scleroderma or vasculitis. Those are diseases that we know that they have a huge connection with our hearts.
Okay, so let's go ahead and dive into those. So probably is the biggest one that you see, is it rheumatoid arthritis?
Yes, probably the most common diagnosis that we treat is still rheumatoid arthritis. When we talk about autoimmune diseases, we talk about, diseases that will affect multiple organs. That's happening in rheumatoid arthritis as well. Many patients, they do come to the physicians to be evaluated for their joints. But when they come to us, we do explain to them that rheumatoid arthritis is a systemic disease that not only affects the joints, that's the trigger that will bring the patient to the doctor, but also rheumatoid arthritis will affect other organs such as eyes or the heart or the lungs and sometimes the kidneys. And that's why we have to emphasize the importance of treating these patients early and aggressively to stop the disease, because otherwise they will end up with other complications.
So give us an example of how autoimmune disease, what you see in a patient if autoimmune disease has been left untreated, and then what kind of cardiovascular problems do you see?
Definitely. So when we think about cardiovascular disease, we usually think about the most common risk factors. We think about diabetes, or we think about hypertension. We think about obesity, or we think about metabolic system or syndrome, metabolic syndrome. But in fact, the cardiovascular risk can be rheumatoid arthritis itself. So I try to explain my patients that if they leave this disease in particular untreated, their risk for cardiovascular disease in 10 years or 20 years doubles, if not triples. And I'll give you examples. So for example, if you are diagnosed with rheumatoid arthritis in your 20s, and you don't care about what's going to happen with your joints, if you're going to develop deformities or not in 10 years, you should care about the fact that your risk to develop a myocardial infarction is 2 times or 3 times more than the general population. And after we adjust for the traditional factors of risk factors for cardiovascular diseases. And you should care about the fact that your risk to develop a stroke is sometimes 1.5 to 2 times higher than the normal population with the same risk factors for cardiovascular diseases.
Wow, I had no idea, honestly. And I'm assuming, I'm thinking about one of the common threads here is probably inflammation. Is that
Yeah.
correct?
That is very correct. I'm going to try to explain to you a little bit what chronic inflammation can do to our body. So for a long time, we thought that immune system and the cardiovascular system are not connected. In reality, they're very well connected. The chronic inflammation can be caused by small injuries to our vessels. And the chronic inflammation itself can have an impact on our vessels if it's left untreated. And what's happening in the chronic inflammation, our immune system is triggered on and on and on. And a lot of these cells, like macrophages or T lymphocytes, they come there to that spot and they start releasing these molecules that are producing inflammation, like TNF alpha or interferon gamma. All of these are substances that will trigger inflammation. And this, in return, they do cause other cells to come and deposit substances there that will cause further injury to our vessels. And in the end, we will develop the atherosclerotic plaques. You all know about the C-reactive protein, right? The C-reactive protein, which is a protein produced by our liver in response to an inflammatory response, is triggering, as a consequence, other molecules like IL-6, which is another pro-inflammatory cytokine. It's another molecule that is causing inflammation, and that will cause an increase in the cardiovascular risk. So in time, people started to use high sensitivity C-reactive protein to estimate the increased cardiovascular risk.
I see. And so C-reactive protein is a way to monitor inflammation, which can also monitor how well the rheumatoid arthritis is being controlled and possibly your risk of MI or cardiovascular accident. Is that correct?
Yes, we do monitor the C-reactive protein and the sedimentation rate. Those are the two most common markers of inflammation that we monitor in people with rheumatoid arthritis. They can tell us if the patient has ongoing inflammation. Sometimes they're not completely accurate, but it's a good tool for us to match the symptoms of the patient with the levels of inflammation in their body. And we use both because they vary in some conditions, SED rate or sedimentation rate can be high, but the C-reactive protein can be low. And in other situations, the other one can be high, and the sedimentation rate could be low. So we pay attention to those two in regards to monitoring the disease activity in rheumatoid arthritis.
I see. So how would somebody know? You mentioned in their 20s, some people might be diagnosed with rheumatoid arthritis. So some people might not know that they have an autoimmune disease, and they basically are walking around with an autoimmune disease, and they're basically putting themselves at risk for a greater risk for a heart attack. So what do you recommend for people to make sure that they don't have an autoimmune disease? Would they know that because they have symptoms, or should they go to a specialist or a primary care doctor to get checked first? What would you recommend?
I think symptoms will trigger the checkup with a physician. If a patient feels well, they will not come to the physician. But usually autoimmune diseases will cause symptoms to these patients. And the most common symptoms that I see are extreme fatigue. That's very common in our patients with autoimmune diseases. I do see rashes, all kind of rashes, especially in patients with lupus. And then I see joint pain or muscle pain. Sometimes they have fever, unexplained fever. They don't have an infection, but it's an ongoing low-grade fever that they notice, and that could be a sign of autoimmunity. And other time, joint pain. People with rheumatoid arthritis, that's what they come to the rheumatologist. First, they see their primary care physician, and I encourage them to see the primary care physician and report those symptoms. The other thing that I tell patients, it's extremely important to keep a diary of their symptoms, because when they go and meet their doctor, sometimes the time is short, they try to address too many things, and the doctor needs a snapshot of what's going on in the last couple of weeks or the last couple of months. So if you go to a visit and you are very well prepared and you lay out the symptoms in a very organized way, the doctor will have a better chance to catch what you have or what you have experienced. And the other thing is that sometimes you go to the doctor and that's the best day for you, and you might forget about the other symptoms that you had 2 weeks ago.
Right, that makes sense. So back on the topic of inflammation, one of the goals of treating RA or autoimmune disease is to decrease inflammation. And
Yes.
so how do we do that? Obviously we could do drugs, and we're going to talk about NSAIDs a little bit later. I don't know if that's I know being a pharmacist, I know that is a treatment, but I don't know if that's always the best thing to move forward, because they are anti-inflammatory, but they also come with some risks. So what are some ways that you talk to your patients about decreasing inflammation?
So I love this question, because I always try to address with the patient what they can do what they can change in their lifestyle to make inflammation less. One of the strongest discussion that I have is related diet. Diet is extremely important, and we can go on and on and on about the anti-inflammatory diet. The other important thing is I emphasize the importance of sleep. Good sleep means good health. The other important aspect of their lifestyle is stress management. Unfortunately, a lot of stress that we put on us, it's going to translate into a lot of inflammation. And the other thing is exercise. I do reinforce the need of pursuing some sort of exercise that will be fitted for their well-being. If they cannot do a lot of exercise, at least they can walk, at least they can swim. So they can start with something that makes them feel comfortable, not overdoing things, but they should pursue that. And the reason is that all of these interventions will help them be less overweight or obese, because obesity could trigger in return a lot of inflammation. You probably know that our adipose cells, they do produce a substance called leptin, and that will trigger another inflammatory response, or that would maintain that inflammation into our body. And it's very interesting that I read a few studies, very, very nicely done studies, that actually the fat that we have inside of our body, around our organs, that is the fat that causes much more inflammation than the fat that we see. So the fact that we have just a sub-Q fat, that produces inflammation, but the fat that we have inside our body, around our organs, that produces much more inflammation. So I'm a strong believer in lifestyle intervention and integrative medicine as part of the treatment before we move on to medication. And as you said, we don't know if it's the right or wrong way to do medication in the beginning, because sometimes it's needed, but sometimes you can wait a little bit until the patient kind of stabilizes their lifestyle, because any medication that we take, it's going to come with a trade-off, right? You know best that.
That's correct. Now, so going back on the fat inside our bodies instead of outside our bodies, that's also called visceral fat, right?
Correct.
Right. And I love this topic. There's a few ways to get rid of visceral fat. Well, I mean, there's more than a few ways, but when I think of it, I think of we had Dr. Shawn on our podcast last year, and he talked about fasting and the importance of fasting and how fasting can help get rid of visceral fat, but just maintaining lean body mass and a healthy body weight in general will help get rid of visceral fat, correct?
That's very correct. Actually, intermittent fasting is coming back. And in the last year, there was an article published in New England Journal of Medicine about the benefits of intermittent fasting in our general health. So I think that we forgot about those principles of life, but they were there for many generations. Our grandparents used to fast certain times of the year, and that's why they live probably a healthier life and a longer life.
Right. I tell you, Dr. Girnita, I love having you on our show because you just preach to the choir. You everything you say about sleep and diet, and that's what we talk about in this show all the time, is that people can be in charge of their own health, and a lot of times it's lifestyle changes that make the biggest effect. So I appreciate you educating our listeners and viewers on that topic. And on intermittent fasting, I mean, one thing I tell patients or just people in general is, when you think about evolutionarily speaking, if you think about what we did generations and generations ago, we were hunters and gatherers. And there were times where we were only hunters, because in the middle of the winter, you didn't have anything to gather. You might have had some stored stuff, possibly, but let's just say you were mainly a hunter. And there were some cultures that's all they did was hunt, because they didn't really have a lot of fruits and vegetables, because they didn't have a long growing season. So, and you think about what they did when we talk about fasting. They would go on a big hunt, and they would, the whole village would get together and they would eat whatever they hunted, and they might not eat for 2 or 3 days after that. And that's how they fasted. And so, unfortunately, in America, most of us have almost an unlimited food supply. When we go home at night, we have a pantry, freezer, and fridge full of food, and we can literally eat all night long. And that's one of the problems, is that, we have, and not only is it processed foods, which creates more inflammation, but also it's just, we have an unlimited amount. And so we are good at storing. I mean, we were taught our bodies are taught how to store food, and that gets stored as fat. So you have any comments on that?
I do, actually, and I love the fact that you pointed that. In the United States, that's true. We have unlimited supplies of food, and everywhere you go, you're going to have something. If you go to a doctor or if you go to the dentist, you find there a bowl of candies, or wherever you go, you find something to snack on. I will tell you something that it's going to make you laugh. Before I came to United States, I had no idea what snacks are. What's this idea of snacking, you know? That struck me because when I started to practice here and I was reading for the, reading certain magazines, they were keep emphasizing these diets with the snacks in between. And I could not understand, why do we have to snack 2-3 times a day? Why is not enough to eat 2 times? 3 times a day is more than enough to eat. And in my culture, where I come from in Romania, we had no idea about snacks. I mean, growing up, I had the breakfast, I had lunch, and we had dinner, and nothing in between. No
Yep.
apples, no peanut butter, no. Uh, I mean, probably if we had access to all of this, we would have eaten those. But most of the time, we had no bars, no cereal bars, we had fruits, but I never thought about this idea of snacks. And I found it extremely challenging, I would say, not to tell my kids that there are no snacks in between, and there is no need for snacks too, because once they went to school, they started to ask for snacks.
Yeah, and our body has, for anybody that's done intermittent fasting, and I've shared my weight loss journey a little bit over the last 6 months. I've lost about 30 pounds, and one of the ways I did it was intermittent.
Congratulations.
Well, thank you. And one of the ways I did it was through intermittent fasting. And I think one thing I want to make clear is that fasting is different for everybody.
Mm-hmm.
I'm an endurance athlete, so I can't go 3 or 4 days without for fasting. Now, there are some people that can. I mean, you read about it, you see it. I know a doctor that really promotes it, and she'll go 2 or 3 days without fasting. Some people think that's dangerous, but our body has an ability to produce energy from fat and our reserves. We are really structured to do that. So, in general, that's not dangerous for most people. Now, if you are a higher caliber athlete or you're doing a lot of activity, it's going to be very, very difficult or possibly impossible to fast like that. But I will tell you, it's taught me how resilient our body is and how little food we really need, how little exogenous fuel we really need. Even being an endurance athlete, on my shorter rides, like an hour, hour and a half long, if they're not super intense, I don't need any fuel. Even on my super long rides, like 3 hours, 3.5 hours, my wife and I have found out we don't need any fuel at all. Water is just fine if they're
Water.
low intensity. Now, at higher intensity, you need to start adding some fuel to your rides and things. But and it's been an incredible journey for me. And I just learned, just like I said, how resilient the body is. Now, we are having a challenge at Mosaic Professional Pharmacy on fasting in July. So stay tuned for that, listeners and viewers. We're going to talk a little bit more about it. I'm going to share my journey, and we're actually going to have a little challenge where we actually check our blood glucoses. I don't know if you know anything about that, Dr. Girnita, but there's a little bit of data going on about, if your blood glucose is high, you probably don't need to eat because that's our energy source. So it's not until you get triggered and your blood glucose goes below a trigger point. It's something I'm experimenting with. I'm finding some success, but there's fasting involved in that. So I appreciate you, educating us on that. Speaking of snacks, I want to share a little story if you don't mind.
Please.
Yes, we all get nervous when we travel because we think, if we're trying to maintain healthy body weight or lose weight, we all get nervous when we travel, and I am no different. So one of the things I try to weigh every day. I even take a scale with me when I travel to the hotel. One thing that I found out is actually when I travel, just like you're talking about, I eat regular meals. Sometimes I don't eat breakfast, but I'll eat like a light lunch and maybe a bigger dinner. And I find out, and I'm like, I'll eat a big dinner, and I'm like, man, I am gonna be really heavy tomorrow. I'm gonna gain weight. But one thing I found out is I usually don't. But at home, if I eat like that, I also start snacking at night after I eat dinner because it's there, right? Well, when you're staying in a hotel, unless you go to a vending machine or whatever, I try to stay away from those. You don't have access to snacks very easy. So actually, I think just like you're talking about, one of the worst things in our American diet is that we are snacking all the time. We just have an unlimited food source where we can snack between meals. That's probably a problem. Even if, and let's just say this, yeah, I get it. Maybe you're eating some almonds or you're eating, a healthy snack or healthy protein. That's still extra calories. And those extra calories will get packed on as fat, correct?
Yes, that's very correct. Everything
Yeah.
you put in your mouth, it's going to translate into something. And as you said, intermittent fasting is different from person to person, and there are multiple ways to practice this kind of approach. However, you have to do it within your tolerance, and you have to do it gradually. You cannot fast for 16 hours in the beginning. Maybe you fast for 12 and then you fast for 14 and then you go further to 18 and later on to 24. But you have to do it slowly to give your body time to adjust. Unfortunately, obesity, as we said, increases the inflammatory markers. And those inflammatory markers, or our diseases with high inflammatory markers, they do impact the insulin resistance. It's very well studied, and we know that the more inflammation you have in your body, the more insulin resistance you have, and the more glucose is floating through your body. So that's something that you have to have in mind when you discuss treatment with patients, and you explain them why they need to be treated, why they will benefit from treatment.
Right. I love it, Dr. Girnita. I love how you institute diet and lifestyle modifications in your practice. And I think, just as you're saying, it's so important. And unfortunately, I don't think a lot of traditional medical doctors, including rheumatologists, from what I've seen, and I'm not personalizing against them or anything, but they want to prescribe, drugs or whatever right away, when a lot of it can be lifestyle, can be changed with lifestyle. So I so appreciate you educating our listeners and viewers and myself. I've learned a lot today on the show. And that reminds me, we are wrapping up. Our time limit is almost up. My producer is telling me, but that's great news because Dr. Girnita, we are going to have you on again and maybe a couple more times because we got some good subjects to talk about. So NSAIDs and cardiovascular health, I think, are very important, but I know I want to have you on for another topic. And today, what I really appreciate is that we got into intermittent fasting. I didn't expect to go down that track, but I'm so glad that we did because I think that is a very important thing when it comes to inflammation and visceral fat and so on. So, Dr. Girnita, with our limited time, in the last 30 seconds or so that we have, what would you like our listeners and viewers to know about autoimmune diseases and how it affects the heart in 30 seconds?
I will tell patients that they have to be proactive about their health. They have to take their health in their hands, and changing small things in their lifestyle will bring them a huge benefit. On the other hand, I want to let them know that sometimes you need medication, and medication is not the enemy, will be your ally in your fight towards autoimmune diseases. In our days, we have so many options that will bring you to a better health, and you are in charge of that. You can come to us, discuss to us about the risk and benefits of certain therapies, but ultimately you are in charge of your health, and you should be our partner in your decisions. The decision should be made with you because it's your life and you are the owner, or you're your own body.
I love it. Dr. Girnita, I think you should host the show because this is what we talk about all the time is that people need to be proactive in their own health. And you as a doctor and me as a pharmacist can help educate our patients, but ultimately they're in charge. I love it. Thank you. Thank you so much. So speaking of being in charge, if somebody wants to get a hold of you, how should they get a hold of you?
I have a website, and it is called Rheumatologist on Call, or they can Google my name and they will find my website. The website will allow them to book an appointment with me, and I'm more than happy to welcome them into my practice.
All right, Dr. Girnita, I love it. You have been so gracious with your time. I know you're busy, and I really appreciate you coming on to educate and empower our viewers, which is the goal of our show, is to educate and empower individuals that they are in charge of their own health. And you definitely accomplished that goal today. Thank you so much. I'm super excited to have you back on. I will get a hold of you so we can schedule some more dates. And I really appreciate you being on, Dr. Girnita. Thank you so much. And
It is my
listeners and
pleasure,
viewers,
Shawn.
you're welcome. And listeners and viewers, thank you for tuning in to Health Solutions with Shawn and Janet Needham. Tune in Monday, 12:30 to 1. So on our weekly podcast, 12:30 to 1, we'll have Charles Foreman on, and you don't want to miss that. He's going to talk about health assessments and health in general. So don't miss him. He's put me in connection with a lot of good people, who one of them I'll be meeting tomorrow in Tucson, Arizona. So thank you so much for that, Charles Foreman. And tune in Monday, 12:30 to 1, where with Shawn and Janet will talk about health. So Dr. Girnita, thank you so much. Health Solutions with Shawn and Janet Needham. Thanks for listening.